Good morning, ICRE. How are you? What did you think of David Ash's opening plenary yesterday? Yeah. He was an outstanding speaker, and I took away so many really important messages, not least of which was that the things that we all do to prepare the next generation of physicians really matter. It matters for patients. So let's use this conference to try and open that black box and find the secret ingredients, if you will, to make a really high-quality program. That's what we're here to share. So Vancouver's treated us really well with some beautiful sunrises, beautiful sunsets. I hope you've gotten out and enjoyed some cuisine and had some wonderful conversations, enriching conversations with colleagues. I encourage you to find one new colleague from somewhere else in the world that you can perhaps collaborate with. You may have heard yesterday this on Twitter that, I don't have my ribbons on, but that Dr. Snell, my good friend, suddenly has more ribbons than I. So I was on the internet last night, and I noticed on Fox News that there was this story, and I think that's just a coincidence, but I'm not sure. I wanted to also issue a new challenge. Sorry about the formatting. I want to issue the ICRESelfie challenge. This is a Twitter-friendly conference. We want you to use Twitter to create an international, a global conversation about medical education, about residency education. So for 24 hours, I challenge you to take an ICRESelfie using the ICRESelfie hashtag. And tomorrow morning, I'll give out a free textbook to somebody as a prize, a medical education textbook that's just released today. John Sherbino is our tweet guru for this conference, and he selected the top tweets, so I'll let you have a look at these. Some quotes from David Ash. Maltaim Hussein says, I'm giving you feedback, pulling out from that feedback workshop as a pre-con. Eric Hombo is saying it's wonderful to have residents here learning about competency-based medical education. And I love this one. As per usual, I have 3 sessions that I want to attend every hour. That's, for me as a conference chair, that's a good conference. All right, so here's some hashtags, some Twitter handles we want you to follow. There is the ICRE 2015 hashtag, and this panel that we're about to launch is Residency Rediscovered. Okay. At this time, I'd like to call up my colleague and close friend, Fiona Moss, the Dean of the Royal Society of Medicine in the UK, to come and chair this opening plenary session. Fiona? Knock him dead.
Thanks. Jason, thanks very much indeed. I have the privilege of being one of the co-chairs of this year's ICRE, and I'd just like to take this opportunity to really pay tribute to Jason, Lisa, Louise, and the team from the Royal College of Physicians and Surgeons of Canada for the work they do in getting us all together for this absolutely crucial international conference. I think their work is absolutely fabulous. Yes, go on, give them a hand. I'm a co-chair, but it's easy for me to say as I am from London, England, as you will have gathered. I'm really pleased to see so many of you here today for this early start to what promises to be a busy and challenging and very productive second day of this conference. So far, some of you will have enjoyed and have taken part in many of the really fabulous pre-cons. And you would have heard yesterday David Ash's extraordinarily challenging and thought-provoking session. I used to say, or I do say, that one of the purposes of residency or medical education is to improve the healthcare, to improve the quality and the safety of care for today's and tomorrow's patients. I think, having heard David Ash, I'm sort of reconsidering that, and maybe the purpose is to improve the health of today's and tomorrow's populations. I think he has a huge amount in that, a huge amount of food for thought about what we're doing and why we're doing it. I just want to go through some of the highlights before we move into the panel session. One of the upcoming highlights from today's programme is Key Lyme Live, a captivating lunchtime session where the bi-weekly podcast Key Literature in Medical Education will be broadcast live from the Vancouver Convention Centre. And on Saturday at 8 o'clock, please join us for the CanMeds 2015, a global perspective plenary session, followed by the official CanMeds 2015 framework launch and celebration starting at 9:15 a.m. The work that has been done in Canada on CanMeds, I think, has absolutely led globally how we consider medical education. CanMeds is part of the discourse of medical education worldwide, and I really do hand it to you in Canada for the work that you have done on that and been such an important global lead. Also on Saturday, we're going to have our exciting plenary debate, and I'm not sure who's in the blue or the red corner, whether blue and red means. I mean, I know there's things called blue jays somewhere in Canada. And I know that one of your politicians that we would call liberal and yellow is actually liberal and red, so the colours are a bit confusing. But anyway, Eric Hombo and Mark Walton are going to go sort of head-to-head or toe-to-toe, I'm not sure which way, in the debate, to debate the challenges and advantages and the problems and disadvantages associated with competency-based education. And I think that should be a terrific session, really getting to the heart of what CBME can give us. And tomorrow night we'll wind down with the physician as wine lover, the sommelier role. Linda Snell, who is our entrusted physician in this, who has, I think, a competency as a sommelier, who's going to help us discover our knowledge, our skills, though presumably we already know about our aptitude in the important role, new CanMeds role. I'm not sure whether the CanMeds role of sommelier is in the 2015 launch. Maybe that's one for the future, for the 2020 version. So the CanMeds role, that of sommelier. This kicks off at 5:45 in the Mackenzie Room at the Fairmont Waterfront Hotel. Now, in between all this, please don't forget to go to the exhibit hall and complete your exhibit passports before Saturday. If you do that, they can go into a pot, and one of you will win a mini iPad. So it's worth doing. So not a lot of effort to put in, but a lot possibly to come out. I would at this time also like to pause and to just get you again to say who the residents are here. Hands up. Yes, fantastic. Same as last night. Give them, please give them a round of applause. The theme of this year's ICRE largely focuses on how residency training is undergoing major transformation. How fitting it is that so many of those who represent the next generation of physicians, although in some ways I would like to call you a current generation because you are today contributing to patient care. I think we shouldn't, we should remember that you are contributing today as well as your continuing contribution over the years. But it's really important you're joining us here today for the kickoff also of the International Resident Leadership Summit. For the next 2 days, these resident leaders will be participating in ICRE programming as well as the tailored resident-focused workshops and sessions. So please, a heartfelt welcome goes out to all the residents here. You are the future of medical education. And those of us who are reaching the dusk of our careers do have a conflict of interest or have a particular interest in you and your education. So as I get older, my interest in medical education perhaps gets a bit more personal and a bit more particular. It now gives me great pleasure to introduce 4 dynamic speakers on this morning's Inspiring Residency Rediscovered panel. The focus of the ICRE 2015 is on transformation, of rediscovering residency education. But there are many among you who have been making extraordinary changes. And we have found 4 people who have not only made changes and are continuing to make changes. I've spoken to them all, and they all admit that they do bear some of the scars of the changes that they made. Change and transformational change is not easy. But it is important, I think, for us to know how it's done and to realise that other people have done it, and maybe we can learn from them. So starting off the conversation, and just to pause, we have got 4 people from 4 different specialties. That's paediatrics, family practice, orthopedics, and internal medicine, representing 3 different countries from 2 different continents. So the experience you're going to see covers a wide range of specialties and comes from a really represents, I think, global experience. Starting off the conversation is Dr. Markku Nousiainen, an assistant professor in the Department of Surgery at the University of Toronto, I've been told to say it. I've been told not to put in the unnecessary extra T, from the University of Toronto, and program director of the U of T's Division of Orthopedic Surgery. His research interests involve development, implementation, and assessment of competency-based residency training curricula, policy in fellowship-level education and in surgical skills education at the novice and at the expert levels. Following Markku, we have Dr. Eric Worm, who is the Richard W. and Sue P. Vilter Professor of Medicine and Internal Medicine Residency Program at the University of Cincinnati. He is an accomplished educator and has won a number of teaching awards and has published widely on medical education. His awards include the Master Teaching Award from the American College of Physicians, the Ohio chapter, and the A.B. Dolly Cohen Award for Teaching Excellence from the University of Cincinnati. Dr. Worm's research interests include creating curricula and systems that improve both education and, importantly, care. Third on our panel is Dr. Mike Donoff, Associate Chair and Professor of Family Medicine at the University of Alberta. His academic work has focused largely on the development of physician competence and health systems delivery parameters, which have prompted his engagement with the development of electronic medical records, physician payment models, and team-based care. As a practicing family physician for 30 years, Dr. Donoff has taught many family medicine residents and says he puts his utmost trust in these graduates to take care of his family, his friends, as well as the public. Finally, Dr. Esam Albanyan will take the stage as our 4th and final panelist. Dr. Albanyan is a consultant pediatric specialist of infectious diseases at the King Abdulaziz Medical Center and the director of the CanMed's Collaboration Center at the King Saudi bin Abdulaziz University for Health Sciences. Dr. Albanyan currently serves on several university and scientific committees that oversee the transition of Saudi residency programs to competency-based education and the integration of CanMed's competencies into undergraduate curricula. We're very fortunate this morning to have the pleasure of hearing from these 4 outstanding medical educators who have been through and are going through the change process. We hope they'll encourage you to think outside the box in terms of what we need to do now to ensure that today's residency education will provide good quality and safe care for tomorrow's patients. Ladies and gentlemen, please give a warm welcome to our 4 outstanding speakers.
Well, thanks for the warm invite and welcome to give our experience of competency-based training in Toronto over the last 6 years, something I'm sure many of you would like to hear an update on. So, so with regards to disclosures, nothing relevant to this talk. So the title of my talk here is How We Radically Change Residency Training, 6-year outcomes of competency-based medical education in the University of Toronto's Division of Orthopedic Surgery. And the real radical change for me was to try and trim down a talk that usually takes about 45 minutes to an hour into 11 minutes. And boy, they were tough on us to trim things down. So I'm going to do my best to keep it in time and keep you well informed, but hopefully you'll have lots of conversations afterwards. So the objectives of this talk are as follows. First, I'm going to discuss the rationale for why we in Toronto think competency-based training is needed in medical education. Second, I'll discuss how our training program initiated a competency-based training paradigm, and I'll review the successes and pitfalls that we've encountered over the last 6 years. Third, I'll discuss what the future holds with regards to competency-based training in orthopedic surgery in Canada and likely generally internationally. So, I don't think anybody sitting here can deny the fact that the time-based resident education model in Canada is facing multiple challenges in 2015. First, resident union bodies have mandated a reduction in work hours. And this is definitely translated to surgical residents spending less time in the operating room learning surgical skills. In addition, certain provinces, such as Ontario, where I practice, have implemented wait times initiatives. Hospitals are now remunerated for efficiencies in having patients be seen by specialists from the time of referral from a primary care practitioner and from the time the patient decides to have surgery in the surgeon's clinic and then when they enter the operating room. This means that I, the surgeon, a teacher surgeon, must be extremely efficient in my patient care activities. Otherwise, my hospital doesn't get paid. In addition, a global movement to improving patient safety has meant that our surgical trainees are much less likely to operate independently. Gone are the days where the trainee could run a list, you look at the x-rays in the recovery room and say, oh boy, we got to bring that one back. Altogether, these changes have translated to a reduction in training opportunities for our residents. The consequence of our current time-based residency training paradigm, which now reaches back to over a century, is that we may be failing to adequately prepare our graduates for independent practice. In a 2009 article in the journal Surgery, Bell and colleagues asked American General Surgery Residency Training Program directors how many of the essential 121 surgical procedures of that specialty had staff supervision during the residency training years. Surprisingly, for 63 of the 121 essential procedures, the modal value of supervised cases was 0, and I don't think it's too different in Canada. In addition, as we heard yesterday from Dr. Ash, the paper that they published in JAMA in 2009 found that where you train as a resident directly correlates with how well you'll practice after graduation. If you graduate from a training program that has a high complication rate, it's likely you're going to carry that complication rate with you. But if you train from a program that has a low complication rate, you'll probably end up practicing with a low complication rate when you go into independent practice. So if you put all this information together, we potentially have a problem here. How can we remedy it? What can we do to change the issues with the current time-based training paradigm in resident education? Well, one option is to consider lengthening training so that our trainees can have potentially more access to the operating room and potential supervision. But we know this is untenable in a day and age of diminishing healthcare budgets, in particular in Canada. So the other option is to consider radically redesigning residency education along the lines of competency-based medical education. So about 10 years ago, Richard Resnick, who was the chair of our Department of Surgery in Toronto, had the idea to implement a pilot residency training program that would be competency-based. He went to all the division heads, and he's a general surgeon. When he went to the general surgery division head, they told him he was crazy. So he went to the orthopedic group, and surprisingly enough, the orthopedics, who everybody thinks are not really real innovators, thought this was a good idea. Ben Ullman, who was our division chair at that time, and Bill Kramer, who was our program director, thought, you know what, that's an exciting idea, let's do it. So under their leadership, our division set forth on designing a pilot training program that would run alongside our traditional training program. Okay, so we have the regular stream residents, and in parallel, we've had CBC residents working alongside of them. After much effort and with the input of leading educators from around the world, the competency-based curriculum was developed, okay? And compared to our traditional time-based training program, this novel training program had a radical redesign in the teaching curriculum, the type of assessments that would be used, and the type and amount of feedback that would be given to the trainees. With the input of our postgraduate medical education office, to whom we owe so much, Sue Glover Takahashi and Melissa Hines, I think they're here, we really have worked a lot with them, and they've been very valuable in helping us go through the process. With the input of our postgrad office, we revised our training curriculum into a modular curriculum, which is broken down into 3 distinct phases, as you can see here on this curriculum map. So you may not see all the definite details here, but this is a landmark or a quick overview. If you look at the first row, that indicates our first phase of training. And that focuses on ensuring that the basic skills and knowledge related to orthopedic surgery are achieved to a competent level. Once the trainees are competent in the first phase, the top, they move into the intermediate phase, which is the middle row. This second phase of training focuses on ensuring the more intermediate skills and knowledge related to orthopedic surgery are achieved. And then the third phase, the penultimate phase, puts everything together. It builds upon the skills and knowledge that are acquired in the first 2 phases and allows the resident to become competent in the more specialized aspect of the surgical discipline. Throughout the training curriculum, it's important to note that all CAMMEDS roles are taught and assessed. We're not just focusing on the medical expert role, as most people think about orthopedic surgeons, broken bone fix. We're really working on developing a true professional in all aspects of the CAMMEDS roles. And these are, the CAMMEDS roles in this curriculum map are highlighted by the different colored boxes. 2 specific CAMMEDS roles are formally taught in each module. And although each module might teach different CAMMEDS roles, cumulatively, over each phase and over the entire curriculum, each CAMMEDS role is taught and assessed with equal frequency. To ensure that our trainees are competent upon leaving a specific module, we also reorganized the assessment process so that formal assessments of our CBC residents would occur at the minimum of 2 time points. The first would be at the midpoint of the module, and we would do this to ensure that the trainee was on track to meet the competencies by the end. And we found this to be probably the most critical area of assessment. Second is at the end of the module to determine competence. In all instances, a number of evaluation tools are employed. These include oral and written exams, observed history and physicals of patients in the clinic, and trustable professional activity forms that assess the ability of our trainees to take care of the pre, intra, and post-operative management of specific conditions relating to a module, 360 evaluations, and forms that capture the level of competence in the specific CAMEDS roles as they relate to the module. This is an example of one of the many assessment forms that we use in the CBC. It's the first page of an assessment form that we use to assess the level of competence in a trainee managing a patient with an ankle fracture. And the grades of level of competence in each aspect of patient care are identified. So, although the CBC uses a number of assessment tools and forms, the idea of all the points of assessment in the CBC is not just for documentation purposes, although it's very useful. The main reason for the points of assessment is that they allow the trainees to obtain both summative and formative feedback on their performance so that they truly understand what their strengths and weaknesses are at any one time. And the numbers show that the CBC has provided our trainees much more feedback than we ever did before. Our CBC residents now obtain 3 to 5 times more feedback on their performance compared to our regular stream residents, as seen in this table. The yellow column outlines the number of evaluations our CBC residents receive in each postgraduate year, while the white column outlines the number of evaluations the regular stream residents historically have received in each postgraduate training year. So 3 to 5 times more. It's a lot of information. So, what have the outcomes been with this new training paradigm? Well, we believe that the residents have benefited the most. We have found that with the frequent feedback delivered, trainees are now able to modify their learning plan in the overall curriculum to satisfy their needs. Some trainees have been able to complete the program in 3 years and 8 months, while others have decided to complete their training in the Canadian standard of 5 years. Our Residency Program Committee has also been able to quickly identify areas of weaknesses in our trainees, and this has allowed us to capture those trainees quickly so that their weaknesses do not perpetuate. The CBC residents have also stated that they all have a higher level of confidence over their regular stream peers, and it's mainly due to the fact that they get so much feedback on their progress. The faculty have had to undergo a specific learning curve as well with regards to the new initiative. Although we've had many early adopters and we owe so much to those early adopters, we still do have faculty that have been a bit more resistant to accept change in their own practice, despite the fact that everyone unanimously agrees that the CBC is the way we should continue to train our residents. Our faculty development process still needs improvement. The program in general has benefited significantly. Since the inception of the CBC in the academic year of 2009-2010, our training program has had countless internal and external reviews by numerous bodies. We've been given the status of full accreditation after 2 Royal College accreditation reviews. It's important to recognize the fact that these reviews have been the first in North America that have accredited a surgical training program that is truly competency-based. So, despite the successes of the CBC, we still have had to deal with many challenges. First, implementing and running the CBC has been very resource intensive. The amount of faculty time and effort, financial support, and administrative support has been much more than we ever expected at the outset. Second, the original pilot program was not time-based. Residents would be on a module for as long as it took for them to become competent, and this obviously led to many difficulties in trainee scheduling. We ran the pilot program for 4 years, but decided for interest of easier scheduling and the sanity of the whole faculty and program administrators to make the training program time-based. Third, our residents have had to adapt to the new changes. They're continuously studying and preparing for the many evaluations they have to face during each module. They've also had to adapt to the fact that the CBC is a resident-driven training paradigm. Although our training programs provides the resources and support for the trainees, it is up to the resident to organize the feedback sessions with the staff, and it is up to the residents to ensure that all their assessments have been completed in a timely manner. In addition, they've had to become familiar with using our online server to access and use all the assessment forms that must be completed. And lastly, as I mentioned earlier, the faculty have had to adapt to the new training paradigm. We have learned that we must continually communicate with our faculty to update them on the changes in the training program. So, keeping in mind the successes and challenges that we have faced with the first competency-based surgical training program in Canada over the last 6 years, what does the future hold for all other training programs in this nation? Well, it's coming their way. Starting in 2018, all orthopedic surgery residency training programs in Canada will have to become competency-based as per the Competence by Design initiative of the Royal College. We hope to assist our colleagues and others as they transition from their traditional training paradigms into this new COMSI-based paradigm. So, in summary, in the last minute, I'd like to just state that we've discussed the rationale for why COMSI-based training is needed in medical education. Second, I've discussed how our training program initiated a COMSI-based training paradigm, and have reviewed the successes and pitfalls that we've encountered over the last 6 years. And lastly, I've discussed what the future holds with regards to COMSI-based training in orthopedic surgery in Canada. Thank you.
Thank you for the opportunity to speak. I, too, have no disclosures to share. I'm here speaking on behalf of my entire team. Even though it's just me, the work I'm about to describe is the work of many, many great people working together. And we're going to talk about our piece in assessment. And like many of you, we've been using milestones and EPAs, but we found them to be really difficult to use in direct assessment. By direct assessment, I mean at the spear point where the assessor and the resident are together using those tools. So imagine you're in a clinic and you're precepting, and you're asked to assess the EPA managed common acute problems across multiple specialties, or multiple settings, which is an EPA for medicine. If you only see a few encounters in one setting, how can you do that EPA? It's a little like asking you, can you drive? You probably all say yes, but can you drive all of those things? So we thought a better approach, rather than this very broad approach, was to be more specific and ask, well, what can you drive and how well can you drive it? So we created a term called the Observable Practice Activity, or the OPA. I realize it's a cheap knockoff of the EPA, but there's a reason for it. Right there in the title, it says what it does. Things that are observable in daily practice, where you don't have to go elsewhere to see it, and they're activities, things that you're doing. And we have two kinds. The first kind they're called content-based OPAs. These are things that are specific to every rotation, like initiate basal bolus insulin, manage blood pressure, or COPD, things you might see on general medicine. It never made sense to me that the endocrinology rotation and the MIC rotation would have the same assessment forms, because the skills we should be assessing are different. So let's be explicit about that. And so these are different for every rotation, and they're different for every level of learner, because we ask different things of them. On the other hand, we have things called process-based OPAs. These are things that are conserved across rotations, because every physician in every setting needs to be good at them, like minimizing unfamiliar terms or using the teach-back method. So these are the same for every rotation. So our forms and our process are specific with some varied elements and things that have some conservation across services. Our rating scale is criterion aligned along the idea of entrustment, Tim Cott's work of entrustment, and we have 6 points of entrustment. So think of a skill like manage pancreatitis. If we rate you a 1, it means we don't trust you even when we're standing there helping you. That's a critical deficiency. We don't give out very many 1s, but they are important. And we're writing a paper right now because there's a debate about whether you should have this on your scale, but we believe that you should. Most medical students enter our residency at level 2, which is you can trust to manage pancreatitis with direct supervision. Over time, they begin to prove themselves and generate trust, and they get to move to level 3, which is we trust you to do these skills with indirect supervision. Us program directors, those of us in the room that are program directors, when we sign the bottom line, when somebody leaves residency, that's level 4. We think that you can do these skills independently, you no longer need supervision. And level 5 is you're so aspirationally good, you can teach the 2s. There is a 6th level, which is this skill produces no score. It's an important level to have because you don't want to have inference. Just because I can see you drive once doesn't mean like you can drive the lunar lander. So it's important to only rate the observations that you've made on this person, and if you didn't see it, don't rate it, you didn't observe it. Here's some examples of some OPAs from picked out one single rotation. Here it is, digestive diseases. For PGY1s, first-year residents, write initial admission orders for GI bleeding, initiate nutrition, perform paracentesis. These are things that you can observe residents do and you can entrust easily. When the residents move up a level, it gets more difficult. No longer is it the pieces of the management, but it's the entire picture and managing GI bleeding, pancreatitis, or immunosuppressive therapy. OPAs are not just for residents. Other people can see the behaviors. In fact, it's very important to get a robust 360-degree view of a resident's performance. So here are some examples of what we ask our allied health professionals to do: respond to pages, demonstrate commitment to pain and suffering. Peer assessments are very important. Peers can see whether you provide feedback or you assist the colleagues in the provision of duties, things that peers can see. And so now we have a very robust system of assessments, even to the program coordinators who check on whether they got their TB tests and get their forms in on time. These are all behaviors that residents can demonstrate are important things to see. Here's our form. I know you can't see the words. Don't worry about that. But this, we just put the OPAs listed down on one side, the rating scale from 1 to 5 here, and all importantly that I didn't see the scale button. We asked the faculty and the assessors to consider each skill individually and discriminate between the different OPAs, not just to straight line it. And we have, and our information system can pick out people who do this and question them on that. It's important, though, that you can't just tell the story in numbers, that narrative feedback has more impact on complex skills than scores. And so we have 3 places for narrative feedback, one of which came born out of necessity. So the box at the top says, if you rated a resident a 4 or a 5, meaning you think they're independent for these skills, or an intern a 3 or above, just justify why. Why do you think they justify this entrustment? This box starts to light up around now, around October, November, when people start to generate trust at whatever level they're at. And if you cannot justify that narrative, then go back and fix your work. And we keep our faculty consistent by using this box. And of course, there's strengths and weaknesses, and we ask for vignettes and try to get as many narrative comments as we can. We hope that these forms in this process will use that feedback for structure. Now, the most important reason to gather assessments is to give feedback to help people get better. And if you can get around that particular thing in your mind, that the reason you're assessing is to help people get better, not to tell the story, but to improve the story, then you've got something. And so we try to get our faculty here. You can see Carl and Lee kind of in the hallway. I don't know if that's compliant with safety. I don't know what it is, but the picture I took. So there it is. And at the end, go through the pieces. Here's how I saw you manage insulin. Here's what I think you can do better. You can see how happy Michael is to get that feedback. That's how all my residents are. They're happy to get feedback. Now, in my position as a program director, I used to have really bad data, and I couldn't ever, it was mostly summative little bits, and now I have a tremendous amount of data. In fact, what I do is I read every piece of data with the resident when they come to meet with me. And now I can see patterns, I can see the picture, and I can develop formative plans. It should be my most important job. It's not to tell the story, but to help to improve the story. It helps to have candy when you're doing this. That's why I have the Hershey's Kisses there. All right, so our system in sum is we have these things that you can observe, content-based and process-based. We map these then to the assessment elements, either entrustable professional activities or in the United States, the reporting milestones for the ACGME. In the past, it was curricular milestones. We have a mapping process. And whenever you give that entrustment score at the point of contact between 1 and 5, those scores are directly transmitted in our information system to the mapped elements. And then I can track these for external reporting over time and for longitudinal assessment, where formative is way more important than summative. So here are the initial outcomes of using the system for the past few years. Each resident receives annualized about 75 assessment encounters. If we just annualized last year, it would be more like 120 because we're getting much better at gathering more and more assessments per residence. A little more than half of the assessments from attending physicians, a little less than half are from all the other people that see residents. They average around 3,700 milestone assessments, discrete, tiny assessments over the course of their 3 years, most of which are attendings because the forms are longer. And we get about 4,000 words of narrative assessment. I don't know what that means. It's just like I count it, so I did. It's about 20 pages of a cheap novel, but it's more than I ever had before. And we use that narrative assessment importantly. Here's what's happened over these 3 years. In this graph, these are the 36 months of residency in the United States, where month would be July of your first year, and month 13 would be July of your second year, et cetera. This is the entrustment scale from, in this case, 2 to about 4.5. And each point represents all the entrustments made in a given month for all the residents, for all the assessors. It's just an average. And what you'll see is that there's progressive entrustment over time. In the black, it's everybody. The faculty start a little lower. Maybe we overrate our residents. They start a little above 2. They never make it to 4, by the way. They make it pretty close, but not quite there. 4 meaning independence for everything. Peers now at a health rate a little higher. Lots of reasons for that, but there's still progressive entrustment over time. It's quite remarkable how stable this line is, and the best fit line is pretty tight. But if you take all 189 residents that have gone through this, the best fit line does go through the middle, but everybody moves at their different pace. Just like we heard in the presentation before, some people are probably ready to go before 3 years is up, and some people probably need a little longer. And so this is a variable path that everybody takes, and if you just take a single resident out of this line, this is what it looks like. It's not smooth. It's bumpy. There are no straight lines in nature, as they say in medicine, nor in assessment. The way we do this information with the Clinical Competency Committee is we collect the information like I just showed you, and what we do with this committee is we divide up all the residents among the committee members. Each person gets about 3 to 5 residents, and they do this pre-review where they read everything I just showed you, all the data, gathering more data if they need, and they come to the Competency Committee ready to report. We show the dashboard I'm about to show you up on the screen, and the person reports out on their resident. It says, this person is doing fine. It's literally a 5-second conversation. But if the person is not doing fine, if there are areas, then we do this deep dive right there in the competency committee, and that is where we develop the plans for remediation, reporting, and feedback. Now, this is a tough slide, I apologize, but this is what our dashboard looks like. The ACGME in the United States makes us report every 6 months on our residency. So the dashboard is split up by the last 6 months of work, a trend line from the first day to whatever day we're in, and some Z-scoring, which I'll describe to you. In the top, this is the 22 medicine milestones that we've mapped to. You could put EPAs there if you wanted. I'm showing milestones. The blue score, the blue line is the resident actual performance. In this case, farther away is better. Scale goes from 2 to 4. The red line is a bit of mathematical modeling that we've done because there's a lot of bias in assessment, a lot of noise. And we did, now that we have 400,000 data points, we're able to do some modeling, and we created what's called a predicted score. What should a resident do if they had this attending physician in this rotation, this time of the year? What would we expect a resident to do? It's a guidepost, nothing more than that. In this case, we can see that red and blue are overlapped. So we say, well, this resident's doing fine from the faculty standpoint, right where it'd be expected. In this case here, in the peer assessments and the allied health assessments, they're inside the predicted score, and there's a real big divot there that's a bit of a problem. And when we follow the trend line, we see that it's kind of coming unraveled here at the end of this person's trend line, and a big problem right here. So this is when we do our deep dive, and we go in and we can see, well, maybe what's the deal here? In this case, it was the critical care nurses who were writing about this nurse. And what, I'm getting old, so I have to put my glasses on here. What this person said was, approaches most skills and decisions with being timid. She requires a lot of backing from more senior physicians. Not only is this resident difficult to approach, she doesn't want to include nursing on rounds. Responding to critical situations doesn't happen. So this is a set of nurses describing a resident's behavior from their perspective. And you might ask yourself, is this a one-off? Is this what the residents always call a personality conflict? And, but we can look into the record and see out of 721 assessments, she's been below predicted quite frequently. This is a pattern. This is something that needs some feedback and remediation, and of course we do that. Now here's a scary point, faculty. Here's the attending assessment from that very same month. Pretty decent scores for a resident, able to calmly handle complex patient care without losing calm. So the assessment from the faculty position was different. The story, the truth is probably somewhere in the middle, and it's important that you gather all that. Lest you think that all my residents are bad, I just want to show out what somebody who's doing well looks like. This person is way outside predicted. Mostly it's boring. Everybody sort of does well. Most people do well. A few people do better than that. This person is clearly maybe entrusted. We could have graduated her early. As it is, we chose her to be chief resident. So like the previous presentation, I have about 4 seconds. This is labor intensive, tremendous value though, bringing to the faculty and to the residents as well. Thank you.
Good morning. It's a pleasure to be with you this morning to say a few words about our assessment system. I have no conflicts of interest to report. We're going to be talking about the competency-based achievement system developed by a team at the University of Alberta Department of Family Medicine, where we have 190 residents distributed over central and northern Alberta in both rural and urban settings. I'm going to start with my first 2 slides talking about why did we design CBAS the way we did. And the first place we started was to ask the question, if we were researchers trying to understand and study competency, we would want to know what is this phenomenon, because that would determine what methods or tools we would use to do our research. And when we did that, we came to this conclusion, which has been written in many places, that competency is a construct which is characterized by being complex, value-laden, and ever-changing. An example of complexity is the situation that when a learner is in a room with a patient, for example, multiple competencies are being used at the same time. And that has a big impact on what tools or processes will work in that situation. Now, when we look at these characteristics and ask, well, what type of research would you use to study this, we came to the next assumption or conclusion that qualitative research methods have a lot to contribute to the design of an appropriate system of assessment. And I would go even further that this narrative language that you've heard already is actually essential not only for teaching and feedback, but for trustworthy summative decisions as well. Now, coming from these 2 assumptions, we came to the third assumption, I'll just go back here, that there is no substitute for our clinical preceptors' engagement. There's no substitute for the observation, the decision of what to pay attention to, and the judgment of a clinical preceptor. Now, my last slide of assumptions is to start with the other observation we make, that not all competencies are equal. Some are low-order skills and some are high-order. And I'd like to share with you what is the pinnacle or the highest competency that our CBAS system recognizes. And it is the ability of a learner to work in a real workplace situation and use the cues, data, and feedback to identify their own learning needs and to take effective strategies to meet those needs. So learners need to demonstrate competence to use triggers in the workplace, identify learning needs, and use effective strategies to attain new skills. Now, in the literature, some have called this guided self-assessment. And the reason it's at the pinnacle of our competencies is because we believe it's essential for lifelong competent practice. So our goal is not only to assure competency being achieved during our residency, which is a 2-year program, but that our residents graduate with the skills and attitudes to seek and use their workplaces to continue growing their competence. So now I'd like to describe what CBAS looks like and take a real high-level bird's-eye view by telling you what the components of the system are. And I do want to point out that the components of CBAS are actually synonymous with those recommended by the National College of Family Physicians of Canada with a program called CRAFT, Continuous Reflective Assessment for Training. So the first component is that we seek a lot of day-to-day observation with a sample of those observations to be documented. And in our system, we call those field notes. Those field notes need to be collected and organized according to a framework and other parameters that make them useful. And in our system, we do this electronically, and we call it a dashboard. And the implication of the dashboard is every learner has access to their full set of field notes 24/7 throughout their entire program. And so do the major preceptors as well as the program director. We do feel it's essential to pull the learner periodically out from the workplace to do a periodic assessment. And in our program, we do that. It's called the 4-month progress review. This is a lot of the places and time where the lesson plan is developed, which you're all familiar with lesson planning. And the final component of a good system for us is the reporting. The resident receives clear and regular reporting, the major teachers do, the program director does, and so does the postgraduate dean. So those are the components, and now I'd like to show you what a field note looks like, because it's the sort of essential substrate of our system. Now this note is taken from the electronic database, and the first thing I'll point out is we do not ask preceptors to describe the event or the situation. The only description is in the title, young woman with chest pain. That's got one purpose only, that the learner and the teacher can both remember what event that was. The narrative part, the text, is all about the feedback. What was the feedback that the teacher wanted to give to that learner at that time? And in this case, the resident did in no way consider pulmonary embolus. So this note is about anybody with chest pain, you must think about pulmonary embolus, and here are some tools that can help you rule it out. So that's the most important component of the field note. The other essential fields, the sentinel, habit, and clinical domain, those are just ways to tag that note according to the framework that you're using. So you could put CanMeds in there if you so wished. But the final field is a judgment. And it's essential to remember that preceptors and learners are told this is a judgment of today's event, not of you as a person or as a learner in general. And there are only 3 levels of performance that a preceptor can choose from. The first is stop important correction. That means that this performance could have hurt somebody or harm a team member. The middle level is in progress, something to consider. And this is where part of it was done well, but the teacher wants to point out how it could have been done better. And the final level is carry on, got it. And this is where the feedback should explain to the resident why they should continue doing what they just did. This is positive reinforcement, which we know is often underutilized and very essential to an assessment system. So do people do these? So we started 5 years ago, And you can see from the beginning we got over 5,000 notes in 1 year, and it's hovered around 5,000. It's actually climbing in the last couple of years, and we're well over 7,000 per year this past year. Now, with that many notes, and especially when you look at it from the learner's point of view, I'm just showing you a slide. I know you can't read the detail of it, but this is to remind you that we do have a dashboard, and when the learner or the teachers log on to this, there are many filters here. They can look at their notes according to performance levels, according to different evaluation objectives, etc. So you may ask the question, with this much data, can we analyze this and ask some interesting questions? For instance, one question is, how many of the notes are stop important correction? How many are carry on got it? Well, consistently, year by year, about 5% of notes are entered as stop important correction, and the rest are almost split evenly between the middle zone, which is here's something to consider, or positive reinforcement, carry on got it. And I just want to emphasize why we think this is important, because one of the concerns about trusting preceptors is that tendency on older forms to just draw a line above average or exceeds expectations. And what we have here is at least half the notes are documentation where the teacher thought the learner could do something better. And we think that's a very important outcome of our approach. Now, my last two slides are to maybe comment on what's the hard work of this now that we are where we are. And it is to continue reminding people why and how the system works. Because when they understand that, they find that the system is quite easy to use. So one question that comes up from preceptors especially is, do you realize how much more observation and teaching I do than what I enter? And we have to remind them back that that's a characteristic of every single assessment system. Every examination is simply a sample of all the things we want to know about the learner. And yet we have to emphasize how vitally important it is for us to capture that sample, because that's what makes for a credible, trustworthy assessment system, is that we can show that we are watching and giving useful feedback. And my final slide is to address another common concern both from learners and teachers. If I say something that isn't quite as reassuring, in other words, stop important correction, is that very threatening to learners, or do teachers hesitate? And we have to remind them with this metaphor that each documented sample, each field note is simply one small tile in a large mosaic, and that it's okay for some of those tiles to be blurry or darker or brighter in different colors, but out of that emerges a more clear picture of that learner who shares in a developing understanding of their competence. So I think I'll stop right there, and thank you very much.
Okay. Good morning, everyone. Thank you for being here. It's a pleasure for me and an honor to be here amongst you, fellow educators, old and new friends. And I want to thank the Royal College and the organizers for inviting me to talk to you today. I'm going to step back. My talk is more of a shared experience, and a shared experience from the perspective of an international program just getting started. I want to share with you how we led change in how we educate our residents at our institution, a process that started in late 2009, early 2010. I want to take you through some of the trials and challenges and tribulations that we had, some of the successes, some of the challenges, some of the experiments that were less successful. Our perspective is an international program that has faculty from various backgrounds. It's an international program that's very early in the process of transition. And with the hope that this might resonate with many of you who are attending today here at ICRE. I know this is a very international audience, and many of you are in various stages of making changes to your programs. I hope this might help you do that. The setting is really, in my institution, it's the King Saud bin Abdulaziz University for Health Sciences, part of the National Guard Health Affairs in Riyadh, Saudi Arabia. It includes 3 large medical centers. They're located in the central, western, and eastern region of Saudi Arabia. We initially focused on the central region. That included about 30 residency programs and about 500 residents. And then over the next few years, we went on to expand our efforts to involve the central and western regions. I'm sorry, the western and eastern regions. One particular challenge for us, many of you may have the same challenge, but for us was that we actually had very strong traditional programs. We had very nicely written curricula, very nice handouts and curricula books that were available in our accreditation body. It was now being put online. A lot of effort went into these traditional programs. I put that in quotation marks. However, the learning objectives were weighted heavily towards the medical expert. The assessments were well organized. They were running well. It was a well-oiled machine. We had a very large MCQ data bank. Our educators and again, accreditation body was very proud of this bank. However, assessment relied heavily on the written test and traditional long and short case clinical exams. Other competencies that we've been hearing about for the past few years, and we're hearing a lot about in this conference, were minimally taught and barely assessed. Another concern was with the national accreditation body. Our Saudi Commission for Health Specialties accept the changes to our programs. If they wouldn't, then we really would not really go far. And another major concern, and this I'll talk more about in my presentation, is would the faculty accept and buy in? And we felt they were key to the success of this endeavor. One thing on our side, there were rumblings of discontent. We felt this was a very important point to pick up on and actually maybe make that even louder. From our higher administration, where assessment and QM concerns, such as incident reports and so on, were not medical expert issues, but rather deficiencies in intrinsic competencies of our practitioners, concerns that fit into areas of communication skills, collaborative skills, system issues. We are hearing it from our own society. We're in the 21st century, with easy availability of internet access and social media. Our patients demanded more of us, and more importantly, from our residents. Our residents felt they were not prepared for real practice in the 21st century. These residents could graduate, they were our colleagues, and we heard from them directly that they felt that at the time of graduation, we weren't providing them what they needed. And we used that as leverage. So we had several ambitious goals. And again, these are very broad, very ambitious, but we had to put some goals. And we started to work on these slowly and chipping away at what we could, looking for these small wins. We needed a broader curriculum. We needed assessments that were very much more inclusive of our other competencies. Our faculty were essential. We needed to educate them. They needed to change in how they taught, and we needed to provide them with those tools and hopefully help our residents become better. We used several arms of approaches, and the first, what we felt it was critical to get our faculty engaged. As I mentioned earlier, they were very happy and very content with our traditional programs. We felt they were key. The residents, from our sort of informal evaluations and meetings with our residents, we felt were on board. They were ready for change. We actively sought consultation, both internal and external. We knew there were many internal hidden champions, faculty who were passionate about resident education. We looked up recipients, for example, of the Best Teacher Awards, and called them up. We looked at the list of our clinicians who either had or were working on their Masters of Medical Education. We called them up, because we felt there was sort of an atmosphere of complacency, again, because of the strong traditional programs. So we looked for these actively, and we called them up and said, come on, we're making some change. And they were very excited to hear from us. We consulted with our colleagues at the Royal College, who were instrumental in guiding us. Time won't allow me to go into details of how they directed us in the right direction and saved us a lot of time. So consultation and collaboration was essential to the small successes that we had. ICRE, for example, became a great platform for our faculty to learn and become energized. We worked on our higher administration. No doubt, as you heard, and I think in almost every talk so far, that resources are critical, and it is resource intensive. So we had to lobby our higher administration for some resources. Saudi Arabia, we're grateful that we do have resources, but it is in the end a pie, and we were actually fighting for a piece of that pie. And for example, so we lobby our administration for our faculty, our program directors to attend events like these and so on. And we use the rising culture of patient safety and role of residents and safe patient care as leverage to get this done. Patient safety was a big issue in our institution overall, and we use that to get more resources and support. A second arm, or a second approach, that I wanted to highlight is we needed a sense of urgency. Again, that feeling of complacency was widespread. We needed to light that fire under our faculty's chairs. So one effective way we achieved this was we conducted actually external Royal College accreditation visits. They were conducted by Royal College reviewers that provided a firm push to our programs. We used Royal College questionnaires and standards that included CanMed's competencies. It was very different, very new to our faculty, a different way of how we did accreditation visits, very different than our own Saudi Commission accreditation process. It provided a sort of trial by fire, as the programs had to rigorously prepare for these reviews. However, we had to emphasize that we sold this as an educational or an academic endeavor. It was not simply an audit. And very importantly, it told us in an objective manner where we were to a benchmark. We gave these reviews weight, again, lobbying our higher administration to provide dedicated time and clinical coverage to our faculty and participate in the reviews. It was an excellent opportunity to train our faculty as reviewers, so we actually ended up with a cadre of reviewers who were trained in Royal College accreditation reviews. We also conducted our own internal reviews, again, using the same standards as an educational endeavor to prepare for the external reviews, and again, was very collegial and educational for our programs. These external accreditation reviews and internal reviews generated reports that we tried to make them transparent, circulated amongst our higher administration, back to the program, giving feedback to the program directly based on these reports, and to our accreditation body. We engaged them. We had to have them involved, and to their credit, they became very interested in what we were doing, and they were engaged with us and helped us. Now, I had to add this slide about what the response was to the accreditation visits, because again, it was a concern that this would be felt as an audit. However, they were actually eye-openers and well received by most of the programs. And most of the faculty, not all, but most, really felt that they were very beneficial to them. There were many of these aha moments, and we were looking for those, understanding that there's a different way to do it. There was a change in the language that included, for example, intrinsic competencies in discussions in the hallways, in morning reports, and other academic activities. There was a general acceptance, but of course we did not expect 100% conversion, at least not yet. Now, a third approach, or a third arm, was to develop our faculty with targeted activities that help us develop them as champions. We had to have parallel workshops and activities that gave them the tools to become part of this process. We established a small center, the CanMed's Collaborating Center. That's main mission was to find ways to raise the standard of residency education at our institution. We recruited and invested in a handful of dedicated clinician educators who will be the foot soldiers in this mission and who are essential. As you can see, this is a huge team effort, and their efforts, both these educators and the champions, was critical to the small successes that we saw. And then from the reviews, we actually had now these cadre of accreditors that would be essential to the next stages. And in the last few slides, I wanted to share with you just a few examples of change, because we gradually started to see some of that change and innovation, how residents were educated. And one example I wanted to highlight was our internal medicine program, because it had its first internal peer review in late 2010. And as expected, there were many areas of non-compliance to the Royal College standards. And this was a program that was considered within the kingdom as one of the strongest programs by our local standards. Now, the second internal review, just over 2 years later, showed several, yet simple, effective changes. One of these, for example, a quick step they did was establishment of the CanMed subcommittee with micro teams for each competency and resident members of these teams. And these little micro teams wanted to ensure they actually lobbied for their own competency to make sure it was included in the curriculum and taught and where it was taught. A second change that the internal medicine program did was to their daily morning report. For us in the internal medicine program, the morning report was a daily activity that was, a lot of teaching was done in this activity, and faculty attended this activity regularly. Residents report cases and have selected cases from admissions and give a detailed report about it. So the structure of this case discussion was changed to integrate CanMed's roles in the presentation. So in addition to the usual history and physical examination and differential diagnosis, residents had to report on the CanMed's role in relation to the case. So for example, in the case of COPD, the resident would have to discuss the manager role in COPD, such as how do you safely expedite the discharge process of patients, or quality indicators of COPD, or the economic comparison of various interventions. And this became part of their regular routine presentations. A third example of what the internal medicine program did, they initiated what was called the end of rotation CanMed's competency appraisal, the IRCA, where residents received this table empty at the beginning of their rotation and gradually filled it in with their choice of cases. So if they had a 1 month or 2 month block rotation, for example, on the CTU unit or with a certain specialty, They would fill the first column with a choice of case. For example, the second case was advanced colorectal cancer carcinoma. This is actually a true residence form that we took as a sample. The resident chose communicator role, his reason being breaking bad news and discussing putting patient on no code with the family. His suggested inputs in this competency, such as providing written material involving religious affairs and so on. And his recommendations for future use in other similar patients or problems or system issues that might be addressed for this competency. There were some other small examples of change, just to highlight. No time to go over the many changes we saw, but in our pediatric program, they developed a mentorship program, but the focus of the mentorship program was looking at the non-medical expert competencies to ensure that those are also engaged with the resident. Our OB-GYN programs in Jeddah, the Western region, the PICO rounds, which were kind of broad, became very structured to address the deficiencies in the scholar role, and it became a regular part of their rounds. The adult ER program in the Central region introduced electronic daily encounter assessments, and again, the objective was to ensure that the CAN-MEDs or intrinsic competencies were adequately represented in the assessment. Where we are in 2015, no doubt we've had some success. We definitely see this wave of engagement. There is a sense of urgency. We know that we need to change. The language of faculty and residents definitely has changed. Our regulatory bodies are very supportive. Within the scientific committees of the Saudi Commission, many of our own faculty who are involved in this process are members of these committees. So the curricula are being rewritten now to include many of these intrinsic competencies to ensure that they're taught. The regional collaborations have been particularly rewarding for us. I think this is probably one important message from this, my short talk, is that the collaborations were critical for the success and the engagement, whether within the kingdom itself or within the regional countries, our neighbor countries. And more importantly, the expectations of our residents had changed. Residents now know they need to become CAN-MEDs competent. The genie is out of the bottle, and they want more, which is important to us. And finally here, definitely we have many challenges. We saw some of these small successes, these small wins, but we still are challenged by how we put it all together, come up with acceptable and applicable CBME across our programs. We've not yet evaluated what we've done. Are we really making an impact? What is working? We still struggle with how to evaluate this, and looking forward to doing that better. There's definitely a huge potential. I think yesterday we heard Dr. Ash talking about the scholar and more research into the area of education. Well, we're definitely lacking in this area, and we need to direct some of our resources into scholarly work on what we've been doing to be able to show our faculty, maybe take it to the next level. We still consider ourselves very early in the stages, and not all the programs have progressed. Definitely the impermeation of what we're doing has been variable. However, our larger programs definitely have embraced it and felt that it's a better way of doing things. So we still have a lot of work to do and many challenges, but I hope this may resonate with some of you here today. Thank you.
Thank you all very much indeed, and thank you for bottling years of work into some short talks. I think you have all demonstrated sort of extraordinary transformation. The reason that we asked them each to bottle their talks and to give us such a concise account is because really now we want to allow you to engage in discussion with the panel. They all said to me that they bear the scars of changes. Things always seem quite easy when they're presented, but underneath, a bit like swans gliding, there is a huge amount of work and difficult stuff going on. So that the two microphones are there, so if you want to come up with your questions. But just while you're doing that, perhaps I'd like to start by asking sort of each of you, what was the greatest barrier that you found and how did you overcome it? I don't know who wants to start on that one. Markku, I think these microphones will work.
Press push. Yeah. Well, you know, I must say the biggest barrier we had was everything, because we had to start, you know, nobody had done it before. We didn't have any assessment for it. We started from scratch. The success there was funding. We were lucky enough to get a significant grant from our Ministry of Health for Innovation, and having support from the lead administrators in our department and university. And the thing is, you can start something and get momentum for a few years. Everybody's in a honeymoon phase, everything's great. But then you're into the later years in your marriage, and you've got to, you know, the honeymoon effect wears off. And that's where you need the perpetual support and funding. And that's where we're at. Early on, people were excited about it. And the issue is carrying it on. And there were a lot of people that got tired out. We're very responsive to change in our training program. We have monthly committee meetings, and we did change. We responded to change. And if you don't do that, then you're going to be in trouble. So I think you got to be responsive, but you definitely need strong leadership and financial support, which is a very hard thing to do to bring change about. Because in medical education, our clinicians are working as hard as they can, and for asking to do a little bit more on top of everything is quite difficult. So we got to think about how to be good at PR as well.
Eric.
Our biggest barrier at the level of assessment was getting the faculty to understand the reason why they were doing what they were doing. It's often busy work at the end of a rotation, just going to get this done. And getting the value statement, which is you're doing this assessment for feedback, and feedback to make someone better, is a barrier you have to overcome if you're going to launch into an assessment program.
How did you overcome that, Eric? And how did you get over that?
Well, be relentlessly positive about the situation, beyond message. I think there's a lot of evidence out there. If you check out van der Vluten's work on programs of assessment and all the work that he's done on this, you'll see a lot of my faculty respond to evidence, so let's show the evidence behind assessment. It's just been relentless positivity.
Well, picking up on relentless positivity, I think the barrier, I would say, is the bias amongst our preceptors against their own trustworthiness giving subjective opinion. They don't trust that subjective opinion isn't more than personality differences. And what's really exciting is when we can actually show them, and there's been literature published here from UBC, what happens when experts watch the exact same phenomenon and then come up with difference. And we say that usually as inter-rater variability, and that the spin on that is that when experts comment on the same phenomena and differ, they usually have valid points of view. And our job is to say an organized system can deal with that. So as a preceptor, give us your honest subjective opinion, and it's going to fit into the system. And when we get that message across, boy, do we ever get it. So I would say, but crossing that barrier is very important.
One of the interesting things I think that brings all your changes together is you all talk about language or narrative in it, which I think is really interesting. Esam.
Thank you, Fiona. I think the greatest challenge, I think I highlighted a bit in the talk, was the fact that it was difficult to get our faculty away from the traditional way of seeing things. I saw the iceberg that was put up just now by Mike, and it reminded me of a tanker heading towards that iceberg, the Titanic, and trying to get it to shift away from that. It was a huge challenge for us, and I think we're getting there, that persistently positive message of change. That was probably our greatest challenge and remains our greatest challenge. The second was our accreditation bodies. Here, I think there's a push from the accreditation body to make the changes. In Saudi, it was opposite. We were making changes before our accreditation body approved it, and we were concerned, and we still, to align it with what current standards are. And if you're doing that, I think you have to engage your accreditation bodies early. Yeah.
Okay, thank you. I see lots of people are queuing up to ask questions. Start over here. Just give your name and where you're from.
Tom Cooney, Oregon Health Sciences University, also the Journal of Graduate Medical Education. Send us your papers. Shameless promotion. Fantastic presentations, but I want to just focus on, I think, picking up the theme of narrative, and perhaps particularly for Drs. Worm and Donoff. Are you looking at using, in addition to your beautiful data, quantitative data analytics, qualitative data analytics, to mine what looks to be a growing body of beautiful narrative qualitative data to really help on the process?
I might jump on that. Dr. Shelley Ross, who's our PhD researcher, and her branch of our team has worked on taking the narrative, in other words, the feedback. We can pull the feedback that any teacher has given, in other words, their field notes, and analyze that. And we've developed an algorithm where we can classify feedback as to how useful it was by looking at the words that were used. And actually, many of our preceptors want that feedback. So we can't keep up with the request to bring me my field notes and give me some faculty development focus to that. But analyzing that qualitative piece is a very exciting piece of work.
I did not know that he was going to say that, but we have something very similar, amazing. Because once we got quantity of feedback, we realized some of it was junk. So we've launched a program where we analyze all the feedback of all of our faculty. A group of us have developed a rubric for that, and then go and give feedback on the feedback. And I meet with all the people that need a lot of help. And you know what? I thought I was going to run into barriers, but they have been great about it. Once they see, oh, this is why you're doing this. This is what's the reason. Well, I could do this better. And so it's a long road. This is not a 5-minute conversation. This is years of work.
Thank you. Some from this side.
Good morning, congratulations. I'm Victor Lara from Mexico. And I have a question because the future of the, in training of the future specialist and in every country, I have one question that I would like to listen to. What is your opinion? What about the, I know that the specialists have to knowledge and skills and abilities, but what about the attitude? The attitude of the, what is the position, the future of the professional exercise? Is honest, ethic, humane, and what happened with the students have the problems, personal problems, but the mental attitude, that the problems that it is coming for financial problems, they come in other countries, they have the problem with the language, we have the stress, because he have a lot of work. I listen that you have thinking about that change, but who evaluate what is the competence, integral competence for the future professional in abilities, human abilities and attitude, and how to support the problems when the resident have problems of I thinking about it. Thank you.
I did want to answer. I think you're asked, how do we manage the resident that actually has a whole galaxy of problems and doesn't seem to be someone who should be progressing? Is that correct? Yeah.
Well, our experience in Toronto is that we are picking up trainees that have those difficulties in the CAMEDS roles right off the bat. We have to fill out an IDER anyways at the end of every rotation. And we capture all the CAMEDS roles on top of the 2 specific ones that we focus on a module. So within the first 6 months to a year, we can really identify trainees that have issues, and it's typically professionalism, right? So we're looking out for that. And because we have so much feedback coming back to the training program, we can quickly identify those trainees and help them overcome their barriers. And in fact, we've had a few trainees that were bad apples early on in the CBC, and with the feedback, first they didn't believe it. The second time they didn't believe it. The third time they started changing way. We had a trainee that changed 360. Really turned out to be a really good trainee in terms of for the medical students, the other residents, the nurses. But without that feedback in the old system, that trainee would have gotten to PGY4 at the review committee, and we say, can this guy go to Ottawa? And by then it would have been too late. So I think if you get continuous feedback on all the CAMEDS roles or core competencies, HGME core competencies, it's going to really help your RPC, help these people remediate.
Eric, comment on
I just wanted to add, I agree. Once you get the data and you see this and it's clear, then you yourself have to have the skills to do something with it. So if you are a program director, these are skills you need to get, and it takes time to learn, but you have to do it.
I think if you remember my slide about guided self-assessment, we use that umbrella to say that the resident who's having difficulty, it's not going to work to fly under the radar. That might have worked because you're facing a lifelong career of increasing accountability as the new professionalism sets in. So we're wanting you to find ways to accept feedback, not always agree with it, and our system allows people to edit the notes in a measurable or accountable way. But the professionalism, certainly about 70% of complaints to our licensing body about professionalism. So we tell our residents, now this is an aspiration. I wouldn't say our system has successfully changed attitudes at this level, but the goal is that this preparation of skills for guided self-assessment and being accountable is a skill set not just to get through our program, but will help you with all the future accountability that professionals will face.
Esam, have you any comments on that?
Hi, my name's Esam. I'm a cardiology fellow at McMaster. My question is specifically for Markku. With respect to the competency-based training that you guys have initiated at Toronto, have you found any differences between the 2 groups that with the usual practice versus the competency-based in terms of like exam results, in terms of practice? And then is there a plan to follow these individuals in their future career going forward? just taking a step back, thinking that, the fact that there has been a new intervention that's been introduced with the residents, with the research team, with the faculty probably quite keen on the competency base, but I'm just wondering whether there's a plan to measure these outcomes in the future.
Well, with regards to performance, the litmus test for us in Canada is passing the Royal College exam. So our training program is pretty good at that, and everybody passes the Royal College exam. The regular stream of training residents never had any of these assessments that we set up in the CBC, so we never compared them. But after the first 2 years, the regular stream residents started complaining about the situation. They were jealous of what we were providing the CBC. And as a consequence, we've had all those assessments be amalgamated into the regular stream of training objectives of training. So in fact, most of our residents now, even if they're in the last 2 years of our group that actually did residency training that was a regular stream, are having all those enhanced assessments. And they're scoring just as well because they're seeing the same amount of patients, they're getting the same teaching rounds, and they have access to all our curriculum maps, all our assessment forms, so they know what the outcomes are. They're studying for it with their colleagues who are in the CBC stream potentially, and they're getting there. So that's the first question. With regards to long-term outcomes, that's a difficult one to tell because we don't, and I wanted to talk to Dr. Ash about this yesterday, but so many people are on him, is to try and figure out a way how we in Canada can get outcomes of our trainees when they go into practice. I don't know anything that's been on that. Maybe our PGME office can help us out, or if anybody else knows, let me know. That's what would be a nice thing to mark out. Again, the N would be very low, right? So we had 14 trainees in our pilot stream before we went to the program going competency-based in total. So, but anyways, that information would be interesting to see. We don't have any plans yet, but again, we have the context with the trainees. We can easily follow them. Anecdotally, some of them have gone into the States to get jobs. We have a real problem with jobs in Canada. So despite our best and brightest competency-based training residents, they still can't get jobs in Canada. One has just actually entered practice in San Francisco. So we'll have to find out the patient outcomes data if they practice in the States versus Canada.
Okay, thank you. Lady over here.
Good morning. Ivy Anderson, the Director of Education at the College of Family Physicians of Canada. Thank you very much to the panel. The four of you are pioneers in CBME, and your work is making change. My question is whether or not you think that we need to change the culture of admission into residency programs for those who are embarking upon the CBME, to looking for learners who are in fact courageous enough to say what they don't know versus proving what they do know, and proving or demonstrating self-reflection skills to help understand what they need to yet further know in terms of looking at further accountabilities in our healthcare system.
Who wants to kick off?
Yes. Absolutely. I'm a program director, and tomorrow I'm going back and then getting ready for recruiting next week. And I think about this all the time. It would be so much easier if we could have a stream of people who already had the prerequisite skills to succeed. And so this isn't just about us in the secondary training programs. It has to be about the step before, and maybe in the step before that, who you recruit to medical school. I completely agree with you. And self-reflection, as we've heard, is probably one of the most important skills a resident needs. There's a lot of literature out there that says we are terrible self-assessors, though, so you got to be careful with that. You can only take it so far.
So just to be controversial, I'll say no. And I'll tell you why, Ivy, is that I think this reflection works when the criteria is, are you going to be good enough to take care of my mother or my family? But prior to coming into my residency, people are competing to get into medical school, and the agenda is ranking, right? Even to get into residency. So when it's ranking, the subjectivity that I said is acceptable starts to be less acceptable. The reflection becomes tainted by, I don't want to show my weaknesses. So I won't go on about that, and I don't really mean a hard no, but I'm just being cautionary how hard that would be to achieve.
But if you live in a summative assessment orientation, then the learner's goal is to pass the test, and you need to be in a formative system the whole way. So we, like the tail, we can't wag this dog. I agree in that way.
But I mean, I think certainly students' residents are quite good. I mean, the assessment tail often does wag the dog. So if they begin to learn that this is how things are changing, and actually it's cool to do formative rather than summative, and actually they see you as their teachers doing self-assessment, self-directed learning, do you think that might just change the culture enough?
Well, I think we should look at it in the admissions setting, but I can tell you I'm just impressed by people who came from a very summative, difficult, competitive environment, and when given an environment where it's safe to to receive feedback, I've seen them turn around a lot. And those, some need extra help, and those are the ones we end up identifying because they're not thriving in our system. So at some point in the system, when the environment's right, I think people do adapt and enjoy it much better.
Okay. Adaption versus selection. Okay, gentleman here.
Fouad El-Naji, University of Ottawa. Thanks for this panel for the great insights. I trained with Dr. Albanyan initially in Saudi Arabia doing pediatrics, and then moved into Canada to do another residency in pediatrics, and have seen the focus from medical expert to CAN meds, and I really valued that change. Just thinking of the objectives training using CAN meds, and the fact that medicine actually evolves much, much faster than any other time in history. Any thoughts on how often we should evaluate or reevaluate the competencies, compared to the previous old system CAN meds role, we evaluate on a cycle, and whether we should reevaluate, every 6 months, every year, every 2, and how the program, especially the orthopedic program, has adjusted to the evolution of medicine and new things adding to the field of orthopedics.
Frequency of assessment of competencies.
From our standpoint, we don't do it frequently enough. That's our current assessment of our programs. And I think we do our end-of-block rotations that can be variable in time. And often at the end of a year, maybe you might get a group of our faculty and evaluators going over our usual scale of assessment. And so we're far from where we want to be. I think the points that were shown where you actually got more, I think Markku showed us that you get more evaluation points and more data points is extremely helpful. Now, you have to have the tools to know what to do with that data. I think for us, we have to work on both ends, collecting more data that's hopefully more authentic and reliable, but also what to do with that data. So we have a long way to go where we are, but we know that we need to do that. We don't do it enough, and we don't have enough data points, and that's where we're hopefully going.
Well, our experience is that it would be great to get a lot of data, but you have to ask your faculty what they can actually handle, right? And when we started off, we wanted to assess all the CAMES roles in each module. When I took over as the program director for the CBC in about 2010, there was like a mutiny in my first meeting. People were saying, this is ridiculous, I got to fill out these forms, it's never going to happen. And we didn't get that information. So we just sat down, we got the input from the postgrad, is that what can we reasonably do in our training program? So these are the questions people have to ask themselves locally and through their specialty committees as Competence by Design rolls out nationally for all the training programs is what can we accept as a national standard for assessments of the CAMEDS roles on a specific rotation. I think it's going to be local and also national depending on the specialty, but those communications have to be made. And then everybody can buy in on it. But if you don't get group input, a grassroots approval, then there'll be a mutiny on the bounty.
I'm going to have one more question because we're coming towards the end of the session. I'm sure colleagues will be around afterwards if anyone's got any questions for them. What's the lady over here?
Neela Lamki from Sultanate of Oman. I really enjoyed everyone's talks. And it's wonderful, we are new in this game because Oman Medical Specialty Board was created only in 2006 and it's really started working in 2007. The problem that we faced, and I have a brief question. The problem we faced is faculty, understanding what are competencies, how am I going to assess them, etc.
Getting faculty on board, a quick one. What are any keys to getting faculty on board?
Keep on meeting with them. And typically how it works for us is that if you set up a meeting that doesn't involve dinner at a nice Italian restaurant, they're not going to show up. So you got to entice them. But really, it's communicate. And we still have people that don't understand what we're doing. So despite you talking with them at faculty reach, et cetera. So I think most people get it, but those that don't, if you're a leader of this, you have to meet with these people directly to really nail down the issue.
I think you should keep it simple and make it relevant to them in the point of contact.
Mike and then Esam?
One thing I'll add is that trying to make change, and if you're early on, that business of change can be very lonely. And so I would encourage you to look for collaborators, people who think like you, get a group that you can actually bounce ideas off and maybe even cry on each other's shoulders when things aren't going very well, but it's a very lonely business. So if you're early on in the process, try to recruit as many people as you can who think like you and can help you achieve your goals. So doing it alone can be very difficult.
And I would echo what Eric said. that time is the most critical thing for our clinicians, and if they are observing and giving feedback, and they tell us they are, doing a note takes 3 to 4 minutes. The big thing is where they're not observing or giving feedback, and we have literature to show that that might be the case, and that's a harder change to make.
It falls to me to thank our panel. I mean, you may be from 3 different countries, 2 different contexts, continents, and 4 different specialties, and maybe different contexts you've been working in, but there's been your generosity in sharing with us, I think, has been fantastic. I think you've all mentioned narrative, which I think has been really interesting in what you've done, and you all mentioned that it wasn't just you, it was your team. So there's all sorts of things came through in the talks. Clearly, you 4 have shown leadership. Really plus, and I think a tenacity, and you've just kept on going. Also, I think another thing, you're obviously very optimistic and positive people, I think has helped you to develop these changes. But I really would like to thank you very much indeed for concentrating your experience and sharing it with us today. And I'm sure colleagues will want to come and ask you questions afterwards during the break. But I think, could you just help me and thank our panel? Just very briefly, I want you to please remember the exhibition hall, which is in ballroom C and D, and there's a couple of reminders. Please remember to download the ICRE conference app. I have, it is really useful. It'll tell you where to go and what to do. If you want to sign up for the mentorship program, please visit the registration desk and choose from our list of MedEd experts for the one-to-one professional development advice. And if you're still gaining your footing in social media world, please be sure to visit the Get Connected at ICRE booth in the exhibit hall, where our tech-savvy residents can set you up with a Twitter account, show you how to download a Keyline podcast, and much more. And finally, don't forget, please enter yourselves in the opportunity to win one of 3 gift cards. To do this, visit royalcollege.ca/ICRE evaluations to complete session evaluations. So again, many thanks to the panel. Please enjoy the rest of the day and the rest of the conference. Thank you all very much. That was fantastic. Really, really, really exciting.